अस्सलाम वालेकुम रहमतुल्लाहि व बरकातुहू व नुसल्ली अला रसूलिन करीम अम्मा बाद फ़ऊज़ु बिल्लाहि मिनश शैतानिर रजीम बिस्मिल्लाहिर रहमानिर रहीम। आप सबको खुश आमदीद कहना चाहूँगा। मेरा नाम फार्मासिस्ट ज़ाद हाशमी है। आज के हमारे इस अनमोल और अनोखे प्रोग्राम में अनमोल और अनोखा इसलिए क्योंकि ये पहली कोलैबोरेशन है दो वॉलंटियर ऑर्गेनाइजेशंस की, गिविंग बैक टू फार्मेसी इन पाकिस्तान और नर्चरिंग कम्युनिटी फार्मेसी इन पाकिस्तान। दोनों ऑर्गेनाइजेशंस का एम और मकसद और मोटिव एक ही है कि फार्मासिस्ट की फलाह व बहबूदगी के लिए पाकिस्तान में क्या किया जा सकता है। उसी हवाले से आप सब जानते हैं कि हमारा अक्टूबर का महीना हर साल ब्रेस्ट कैंसर अवेयरनेस के हवाले से मनाया जाता है। पहले एक दिन मनाया जाता था, लेकिन इसकी बढ़ती हुई नौयत और शराइत की वजह से इस पूरे महीने को ही इससे मंसूब कर दिया गया है। हम खुशकिस्मत हैं कि हमारे पास इस हवाले से तो बहुत ही बेहतरीन और काबिल कदर फार्मासिस्ट मौजूद हैं, जिन्होंने ना सिर्फ फार्मेसी बल्कि कीमो की दुनिया में बेतहाशा जो है वो काम किया है। वो दोनों फार्मासिस्ट हमारे साथ आज मौजूद हैं। दोनों जो हैं वो कोर मेंबर्स हैं, एक गिविंग बैक टू फार्मेसी इन पाकिस्तान के और एक नर्चरिंग कम्युनिटी फार्मेसी इन पाकिस्तान के। तो सबसे पहले आप सबसे मैं ये कहना चाहूँगा, गुजारिश करना चाहूँगा कि आपके कोई भी सवालात हों आप सेशन के दौरान भी पूछ सकते हैं, आप सेशन के जो है वो बाद में भी पूछ सकते हैं, आप चैट में जाके वो सवालात लिख सकते हैं ताकि जो है हम वहाँ से जो है वो आपके सवालात के जवाबात ले सकें। बगैर किसी देर के मैं चाहूँगा कि पहले फार्मासिस्ट का तारुफ कराऊँ। हमारे साथ जो पहले फार्मासिस्ट मौजूद हैं, डॉक्टर मंसूर अहमद खान। He is a senior clinical pharmacist, oncology, hematology, bone marrow transplant, Ministry of National Guards, Health Affairs, assistant professor, KAU member, PNTC and MNGHA, और हमारे गिविंग बैक टू फार्मेसी इन पाकिस्तान के कोर मेंबर भी हैं। और ये बात करेंगे ब्रेस्ट कैंसर ट्रीटमेंट के हवाले से। ओवर टू यू सर, यू आर रिक्वेस्टेड टू प्लीज शेयर योर स्क्रीन। थैंक यू।
Assalamu alaikum wa rahmatullahi wa barakatuh. Can you see my screen?
वालेकुम अस्सलाम सर, जी बिल्कुल, we can see your screen.
Good afternoon, everyone. Thanks, Dr. Saad, for a great introduction. And first of all, I would like to wholeheartedly appreciate and thanks Giving Back to Pharmacy in Pakistan and Nurturing Community Pharmacy in Pakistan for putting this great show, arranging this webinar in order to have the awareness of the breast cancer screening, prevention, and management as within the month of the October, which is the month of the breast cancer awareness. So these are my objectives. We have positive time, so because of positive time, we'll touch upon only a couple of areas of the breast cancer. So I'll talk about the risk factors associated with the breast cancer, and I'll briefly touch upon the NCCN clinical practice guideline recommendation for the different stages of the breast cancer. And I'll briefly touch upon endocrine therapy for the management of the breast cancer. And if I had time, because I think I don't have time, I wanted to focus on CDK4/6 inhibitor with the clinical trial, randomized control trial in the first line and second line setting. But because of paucity of time, probably I have to skip that part. But the organizer of this webinar, Dr. Zaad and Dr. Afsa, they can share my presentation with whoever is interested. And I will have my emails towards the end of my presentation, and you can also send email to me if you're asking any questions or if you need my slides. So let's move to the statistics of the breast cancer. So the breast cancer is becoming the globally the most common cancer internationally in the whole world. And have a look at the statistics in the United States. The breast cancer incidence in the United States is in 2021 is expected to be 281,000 newly diagnosed breast cancer patients with prevalence of about 3.8 million. If you compare the incidence of the breast cancer in the United States, it's 10 times, a tenfold proportionally more than what we have seen in Pakistan. According to the Global Cancer Observatory Report of 2020 for Pakistan, the incidence of the breast cancer in 2020 was 26,000 patients were newly diagnosed with breast cancer, which is proportionally much more lesser as The population of Pakistan is about 220 million, and the population of the United States is about 330 million, with a prevalence, 5-year prevalence of about 60,000 patients. So moving to the etiology of the breast cancer. So hereditary breast cancer represents 5 to 10% of all breast cancer. And one of the most, the commonest hereditary causes are mutation in the oncosuppressor gene, which are BRCA1 and BRCA2 mutation. And generally, these mutations are found in about only 0.1, 0.2% of patients, but those patients who have breast cancer, diagnosed with breast cancer, they have about 3 to 4% of breast cancer patients. They have this BRCA1 and BRCA2 mutation. And patients, those who have triple negative breast cancer, but ER, and HER2 negative breast cancer, they have higher incidence of harboring BRCA1 and BRCA2 mutations. So anybody who has BRCA1 and BRCA2 mutation, that is a tumor suppressor gene, they have likelihood of having breast cancer, and also there is increased incidence of other types of solid tumors, such as prostate cancer and pancreatic cancer. And then we see in about 25% of patients over amplification of the HER2/neu, which is progression gene, and it's prognostic marker because historically it has been associated with poor prognosis, especially in the era where there was no HER2/neu targeted therapy. Dr. Smirnova will talk about that in particular in details. And it's predictive biomarker as well, as we have lots of target therapies for HER2/neu positive breast cancer. About 70-75% of patients, they have hormone receptor positive breast cancer, which is ER/PR positive breast cancer. So the malignant progression usually involves early changes in proliferation of these hormone ER/PR for the malignant progression of breast cancer. So talking about the risk factors, age is the single most, one of the most important risk factor. There are different risk calculators. There's the Gale model uses age more than 35, but usually the patient crossing the 5th decade of the age, like more than 50 years in postmenopausal age, and when they're crossing 6th and 7th decade, there are super high risk of developing breast cancer. And those patients who have breast cancer, their first and second degree relatives are at the risk of developing breast cancer. And then prolonged estrogen exposure is also—
Dr. Masoor, we cannot see your screen. Yes.
You cannot see my screen? It's being shared. You cannot see my screen?
Yes, sir. Yes, we can see it now.
Yeah, I can see it's being shared. Okay, so those people, those patients who have early menarche, typically less than 12 years of age, and late menopause, are nulliparous women, are those women who give rise to the first child after 30 years of age that are at risk of developing breast cancer. Then who are on hormone replacement therapy, have patients having benign breast disease, and Hodgkin lymphoma patients receiving chest wall radiotherapy that are at high risk of developing breast cancer. And patients with obesity and lack of physical activity is also associated with the risk of the breast cancer. So trying to understand a little bit the anatomy of the breast cancer. So here is an example of the breast ductal carcinoma in situ. So you can see here, if you can see my cursor moving here, so these are the lobe where the milk is produced, and these are the ducts which are carrying the milk to the nipple. So if the cancer is here, the lobe, that's called lobular carcinoma. That's seen in about 15% of patients, in very invasive lobular carcinoma. And the invasive ductal carcinoma, which is most common, is seen in about 70% of patients, and it carries one of the worst prognosis. So we have pathologically 4 different types of breast cancer. We have ductal carcinoma in situ, and lobular carcinoma in situ. We just talked about that. And invasive lobular carcinoma is the one which is invasive. It can spill out and it can invade other tissues and organs. And invasive ductal carcinoma, it can also spill out and it can invade other tissues of the breast, and it can metastasize to the other organs as well. Typically, any patient who is diagnosed with breast cancer, he or she goes through this typical scenarios. A patient may have silent symptoms of breast cancer, so which is typically like most of the patient have, like 90% of patients have painless lump in the breast tissue, or they may have itching pain, or they may have nipple discharge. So they ask medical help, and then the doctors physically assess them, and they may order mammogram And if the mammogram is suspecting a lesion, that may need to be further investigated by the breast ultrasound or breast MRI. If patients are super high risk for developing breast cancer, you can also do the breast MRI. And Dr. Smina will talk about probably risk minimization strategies. If the lesion is suspected to be malignant, then the biopsy needs to be done. And in pathology, we look at ER, PR, and continuum status. And those patients who have BRCA1, BRCA2 mutation, they need genetic counseling. And oftentimes we use alkylating agents for the management of the breast cancer and other chemotherapeutic agent. We can cause infertility. So these kind of patients also need the fertility counseling as well. Then we do imaging, CT chest, abdomen, pelvis, plus minus brain CT scan or MRI, and bone scan in order to see whether there is an metastasis. Metastasis means that the disease has spread from the breast cancer to the other parts of the body. And we do, of course, the complete blood count, liver function test, and we do basic screen, including creatinine and electrolytes in order to see whether the patient is fit for chemotherapy or not. So, for example, if the patient has received the chemotherapy and we have to do a complete blood count before the next cycle of chemotherapy, trying to make sure that the patient have enough neutrophils and platelets. And if not, then we may have to delay chemotherapy or dose reduce chemotherapy. Staging is typically not the pharmacist's job. This is the job of the physicians. So you're not required to know how to stage the patient for breast cancer or any other solid tumor. But what you and I are required to know, what is the treatment recommendation for the different stages. And if you are going to take the BCOP exam, so you're going to be tested, you're not going to be tested how to stage the breast cancer, but you're going to be tested in the BCOP exam, what is the treatment if you know the stages and the time of the breast cancer. So like any other solid tumor, use the TNM staging for staging the breast cancer. So T stands for the size of the tumor, N is the lymph nodes, and M is the metastasis. So we have stage 1 till stage 4 disease. So stage 1 and 2 and 3 are locally advanced disease, or early stage breast cancer, where the stage 4 is the metastatic breast cancer, where the cancer has metastasized to the other parts of the body outside the breast cancer, outside the breast tissue. So one of the key element in the management of the breast cancer is the surgery. So whenever the patient has breast cancer, early stage breast cancer, the treatment is to remove the breast cancer by surgical resection. And after that, we need to see what is the risk of the recurrence of this breast cancer. If the risk of the recurrence is higher, then we have to give some kind of chemotherapy after the surgery, and that's called adjuvant chemotherapy. And there are many prognostic tools in order to risk categorize into high risk and low risk for recurrence. And we have adjuvant online. We have Oncotype DX, which we do in our hospital, is 21 gene RT-PCR. Mammoprint is 70 gene. RT-PCR and PAM50 is 50 gene analysis assay. So based on the risk categorization that we learn from doing these prognostic tools, then we decide whether or not we need to give adjuvant chemotherapy to the patients. The management of the breast cancer is involving multidisciplinary team approach. So we need surgical oncologists, we need radiation oncologists, we need medical oncologists, we need clinical pharmacists, we need nurses, using the cutting edge of biological therapies, novel biological agents, chemotherapy, conventional chemotherapy, novel endocrine therapies, especially in endocrine resistant diseases, in order to provide optimal care to our patients. For surgeons, there are lots of options. So people can do breast conservation surgery, which is quite a popular fashion these days. So we would like to have the breast conservation surgery. That means we do the minimal surgery. And for that reason, you oftentimes need chemotherapy before the surgery in order to shrink the size of the tumor, and that's called neoadjuvant chemotherapy. And then you do minimal surgery, but we definitely need to achieve the negative margin. And after that, we definitely need to give adjuvant radiotherapy and chemotherapy in these kind of patients, and of course the endocrine therapy for 5 years at least. Some patients would like to go for the mastectomy, And then the surgeon, they have to do the excisional dissection for the surgical staging of the breast cancer and sentinel lymph node biopsy. And surgeons, they have to do the reconstruction for the breast restoral patient as well. The radiation oncologists can offer external beam radiation or internal beam radiation. And as a pharmacist, what we are supposed to know is chemotherapy regimen. So there are different kind of chemotherapy regimen used for the management of the breast cancer and early stage breast cancer as well as metastatic breast cancer. There's no standard one regimen to use for the breast cancer. So there are lots of different regimens. So historically, we are familiar with the CMF, which is cyclophosphamide, methotrexate, and 5-fluorouracil. We have been using it quite a lot. And it's equivalent to AC, which is adriamycin and cyclophosphamide regimen. But if you use triplet, such as AC in combination with taxanes, that's superior to CMF. So we have intracycline-containing regimens. There's AC, FEC, FAC. We have taxane-containing regimen, which is particularly of huge importance for lymph node positive disease. And then for HER2 positive, we have trastuzumab-containing regimen, and we use doublet trastuzumab, pertuzumab combination for neoadjuvant and adjuvant therapy, as well as in metastatic breast cancer. So decision to choose which chemotherapy regimen is good for the patient. It depends on a lot of factors, like tumor factor, like the size of the tumor, whether they're not lymph nodes involved, the grade of the tumor, grade 1, grade 2, grade 3, whether they're not ER/PR and HER2 positive or not. These actually affect in selection of the chemotherapy regimen one or the another. Then the patient characteristics, advancing age, you have limitation of using doublet or triplet in this kind of patient. A patient having comorbidities such as cardiac insufficiency, you have the limitation that you can't use intracycline, as intracycline can cause cardiac toxicity. And those patients who have received multiple lines of therapy before, then you can't offer them intensive chemotherapy. And those patients who have poor performance status, there's performance status of 3 and 4, you can hardly offer anything to these kind of patients in comparison to the patients who have good performance status, such as 0 to 1. And then patients are very well educated, so they know about the treatment, different lines. So they come to physician office, and they oftentimes come to us and asking about different lines of therapy. So patient preference is definitely the one also affecting the choice of chemotherapy. And then oftentimes we see a new clinical trial is published, a clinical practice guideline, the national practice guidelines, the NCCN guideline, ASCO guideline, ASCO guidelines are updated. So we are obliged to follow these guidelines and try to treat a patient in line with international guidelines, updated guidelines. And sometimes we attend international meetings, ASCO meeting, and we see reports presented in those kind of meetings, and then we come back to our clinic and we try to see those patients and try to use those kind of chemotherapy protocol in our patients. So coming back to the treatment, coming to the treatment by stage, as per NCCN guideline recommendation. So quickly, I will wrap it up. So early stage breast cancer, stage 1 till stage 2, the goal of therapy is cure. So how can you achieve the cure in this kind of patient? By surgical resection. So one of the most important pillar of the management of the breast cancer is surgery. So cure can be achieved only by surgery. So we talked about different types of surgery. However, you might need in some patients like pre-operative chemotherapy in order to shrink the size of the tumor, as some patients would like to go for breast conservation surgery, so they would like minimal surgery. And then after the surgery, you also need to give them adjuvant chemotherapy. That depends on the characteristics that we discussed earlier. We can have a look at the patients, those who have tumor size less than 0.5 centimeter, with no lymph node involvement, you don't need to give them adjuvant chemotherapy. But the patient, those who have more than 0.5 centimeter, and you have to do oncotype DX, which is 21 gene RT-PCR, is category 1 recommended option in NCCN guideline. If the RT-PCR written score is less than 26, you don't need to give chemotherapy, but you give adjuvant endocrine therapy, which is tamoxifen for 5 years if premenopausal woman, and aromatase inhibitor for 5 years if postmenopausal woman. If this written score is more than 31, then adjuvant chemotherapy is recommended, followed by endocrine therapy over 5 years. If the patient has a tumor, any tumor size more than 0.5, and they have HER2 positive disease, there is no question of doing any kind of these prognostic tools, because these prognostic tools were not validated for HER2 positive disease as well as for triple negative breast cancer. So triple negative breast cancer, again, whenever you have a triple negative breast cancer, it's associated with worse prognosis, so you have to consider giving them adjuvant chemotherapy after the surgery. Now, stage 3 disease, when you have the tumor size T3, which is more than 5 centimeter, or any size of the tumor involving connected with the chest wall. So the goal of therapy, again, is cure, because disease is not metastasized to the other parts of the body or other organs of the body. So, but what we have to do as a standard of care here, we have to give preoperative chemotherapy. The purpose of giving preoperative chemotherapy is to reduce the size of the tumor, downsize the disease, and make the surgery easy for the surgeon. So we give typically 4 to 6 cycles of chemotherapy, and then we evaluate the patient when we take the patient to the operating room. And in HER2 positive and triple negative breast cancer, we have more patients achieving pathologically complete response rates, which is more than 50% or up to 60%. That means when you take the patient to the operating room, there's no tumor left over. And if there is a pathological complete response achieved, that's associated with good prognosis. If there's a residual tumor after giving a neoadjuvant chemotherapy, that's associated with poor prognosis. So typically you give preoperative chemotherapy, evaluate the response, and then do the surgery. And after surgery, you give adjuvant chemotherapy, radiotherapy, and endocrine therapy if they are hormone receptor positive disease. And adjuvant endocrine therapy that we talk about always in ER/PR positive disease after giving chemotherapy, we have to always give them endocrine therapy, which is in premenopausal women, we give tamoxifen for 5 years, category 1 recommended treatment option. You can give tamoxifen for 5 years, and if they achieve postmenopause, then you can continue aromatase inhibitor for another 5 years. So you can give endocrine therapy in adjuvant setting either 5 years or 10 years, 4 or 5. In postmenopausal setting, recommendation is to give aromatase inhibitor for 5 years, or you can extend it up to 10 years. So these are the different regimens in the preoperative setting. So preferred regimens are usually triplets. So you use dose dense AC. Dose dense AC is defined as every 14 days. You know, AC is adriamycin and cyclophosphamide used to be given every 3 weeks, and paclitaxel used to be given every 3 weeks. And you don't combine adriamycin together with paclitaxel because this interaction results in more cardiotoxicity. So you have to separate doxorubicin from the paclitaxel. And the studies have shown if you give those dense regimens every 2 weeks versus every 3 weeks, it's associated with better outcomes. And the studies have also shown that if you give paclitaxel every 3 weeks versus weekly paclitaxel, that's associated with better outcomes. So in my practice, what we use dose dense AC followed by weekly paclitaxel. This is the most common fashion. And if the patient has cardiac insufficiency, then we can give them a regimen like doublet without having any anthracycline, because anthracycline can cause cardiac toxicity. So anthracyclines are doxorubicin, epirubicin, which are used for the breast cancer. Idarubicin and daunorubicin are used more commonly for leukemia. PARP inhibitor can be used in if the patient have germline BRCA1 mutation, and a triple negative breast cancer, you can use immune checkpoint inhibitor pembrolizumab based regimen in neoadjuvant and adjuvant setting. In metastatic breast cancer, the goal of therapy is not curative. So all the chemotherapy that we give is basically given with the intention to palliate the symptom, not to prolong the life of the patient. So it's not good to have metastatic disease, but if the patient presents with the bone and soft tissue metastasis, that's associated with better prognosis in comparison to the patient presenting with liver, lung, and brain metastasis. That's associated with poor prognosis, and usually crises happen in that kind of situation. So it's debatable, like what chemotherapy is recommended for metastatic breast cancer. There is no single standard of care again in metastatic breast cancer. So it all depends on the performance status of the patient and the comorbidities. If the patient is young, no comorbidities and no performance status issues, so we can use doublet or triplet in these patients. Otherwise, we can use single agent or doublet in these kind of patients. These are the different regimens. I think you can out of Afsa, Dr. Zad, you can have my slides and you can go through. You can log on to NCCN guideline, which is free subscription for oncology pharmacists taking BCOP exam. You are required to not only read the BCOP pharmacotherapy handouts, but also you need to look at the NCCN guideline, which is changing every 3 to 4 months. So these are the regimens which can be used for the management of the metastatic breast cancer. So we can see single agent medications such as anthracycline, taxanes, microtubule inhibitors, and there's doublets, such as AC, and there's triplets, such as CMF, etc. And for patients who have ER/PR positive metastatic breast cancer, so the NCCN guideline here is showing the standard preferred regimen in first-line setting. So we give aromatase inhibitor and CDK4/6 inhibitor. Actually, I wanted to talk about in detail about the CDK4/6 inhibitor, but maybe we can defer it to another session later on. We have 3 CDK4/6 inhibitors: abemaciclib, palbociclib, and ribociclib. As category 1 recommended treatment option to use aromatase inhibitors with an estradiol or letrozole in combination with one of these CDK4/6 inhibitors. Newly diagnosed ER/PR positive metastatic breast cancer, HER2 negative breast cancer with no visible crisis, so you can use this. Or you can use fulvestrant in combination with CDK4/6 inhibitor, and all these regimens are preferred regimens. And if the patient has received before endocrine therapy and progressed on endocrine therapy, then second and subsequent lines of therapies include, again, fulvestrant in combination with CDK4/6 inhibitors. And those patients who have PIK3CA mutation can use alpelisib in these kind of patients. You can also use everolimus in combination with endocrine therapy, so exemestane, but it's terribly toxic medication, especially stomatitis is really significant. But if you use like stomatitis mouthwash in the first couple of months, and probably you can try to minimize the severity of the stomatitis that we see with everolimus in our patients. So here we have some of the doses of the endocrine therapy that we use. So we have tamoxifen, which is selective estrogen receptor modulator. We use 20 milligrams daily. So side effects are hot flashes, vaginal discharge, mild nausea, thromboembolism, endometrial cancer. For hot flashes, we usually use antidepressant, fluoxetine, but that can interact with the tamoxifen and reduce its metabolism to active metabolites. So we recommend not to use fluoxetine to treat the hot flashes with tamoxifen, and I recommend venlafaxine. So you can use fulvestrant, 500 milligram, day 1, 15 and 29, and 500 milligram once monthly. These are the aromatase inhibitors, estradiol, letrozole, and exemestane. And we have the LHRH analogs, discozaridine, lipolide, and triptorelin, which can be used as for ovarian suppression in combination with CDK4/6 inhibitor and premenopausal women. For CDK4/6 inhibitor, it's really an important pathway which is found to be overactive in many number of cancer cases, including the breast cancer. So if you use CDK4/6 inhibitor, it leads to activation of one of the onco-suppressor gene called retinoblastoma gene that results in cell cycle arrest. So 3 agents have been approved by FDA and EMA, which are palbociclib, ribociclib, and abemaciclib. We use palbociclib 3 weeks on, 1 week off fashion, and ribociclib also 3 weeks on, 1 week off fashion. And the most common toxicities are bone marrow suppression, and ribociclib has additional toxicities of QTc prolongation and hepatotoxicity, whereas the abemaciclib is used continuously and it's used twice daily, not once daily, and its bone marrow suppression is less frequent. And the key unique toxicity of the abemaciclib is grade 3 to 4 diarrhea, seen in about 20% of patients. So with the monitoring parameters for the CDK4/6 inhibitors, palbociclib and ribociclib both are known to cause grade 3 to 4 neutropenia in about 50 to 60% of patients. So we recommend to do CBC every 2 weeks for the first 2 cycles, and then do the dose adjustment based on grade 3 to 4 neutropenia, between grade 3 to 4 neutropenia. You also do CBC for the palbociclib, although it's associated with the grade 3 to 4 neutropenia in only about 20% patients. You do additional tests for ribociclib, electrolytes, and ECG because of QTc prolongation, and that's not what you see with the others. And with the abemaciclib, you need to monitor the patient for signs and symptoms of diarrhea and dehydration, as grade 3 to 4 diarrhea has been seen in about 20% of patients. So I will skip these trials because of paucity of time, but you can have you can see like a significant response rate, progression-free survival when CDK4/6 inhibitors are used in comparison to the standard of care therapy like aromatase inhibitors. Because of paucity of time, I have to go over them quickly. Just I will comment here. In these 3 trials, palbociclib in second-line setting was evaluated in PALOMA-3 study in a randomized control trial where the palbociclib arm was associated with progression-free survival of about 9 months versus fulvestrant about 4 months, which is typically now median progression-free survival with the fulvestrant. But if you look at the MONALEESA-3 study, the progression-free survival in the control arm is 12.8 months, which is more than the intervention arm of the palbociclib. So the reason was that in MONALEESA-3 and MONARCH-2 study, most of the patients enrolled in second-line setting were endocrine sensitive. That's why the magnitude of the outcome was over-exaggerated in comparison to palbociclib PALOMA-3 study. So that does not mean that ribociclib and palbociclib is more effective than palbociclib. All of them, they are very similar. Only the patient population selected in these 3 trials were not similar. So this is the last slide, the selection criteria for the CDK4/6 inhibitor. So I choose palbociclib and ribociclib in patients who have good bone marrow reserves and have not received different lines of therapy before. In comparison to abemaciclib, I use abemaciclib in those patients who have poor bone marrow reserve, who have received chemotherapy before and were at risk of developing neutropenia and thrombocytopenia. Whereas those patients who have any cardiac or hepatic insufficiency, I don't want to use your ribociclib in those patients. I would like to use palbo or abemaciclib. And those patients who have IBS or ulcerative colitis, they're at risk of developing severe or diarrhea, so I don't recommend abemaciclib in those patients. I recommend palbociclib and ribociclib. And if the patient has a brand metastasis, I recommend only abemaciclib in those patients because only abemaciclib is the one which can cross the blood-brain barrier, not ribociclib and palbociclib. You can argue with me, everybody can argue with me that ribociclib is approved in premenopausal women based on the MONALEESA-7 study, but NCCN guideline does not differentiate in any one of them, and they say they're all the same in pre, peri, and postmenopausal women. And you can use mTOR inhibitor, everolimus. The patient has failed first-line endocrine therapy. You can use alpelisib, which is PIK3CA inhibitor in PIK3CA mutated patients. And PARP inhibitor can be used in BRCA1, BRCA2 mutated patients. And immune checkpoint inhibitors, pembrolizumab, can be used. Remember, atezolizumab, when it was approved based on IMpassion130 trial, has been revoked by the US FDA based on the inconsistent evidence. And definitely in 70 to 80% of patients, we provide supportive care to the breast cancer patient or solid tumor hematological patients in comparison to reviewing of chemotherapy protocol and stuff like that. So we have to make sure the chemotherapy-induced nausea, vomiting, prophylaxis is provided in our patient. And a lot of time we use those dense regimen, paclitaxel, docetaxel, we can call neutropenia, febrile neutropenia, and intracycline and heterogeneous positive targeted therapies can cause cardiotoxicities. So we need to try to prevent the cardiotoxicities with these patients. So how can we do that? We don't combine, for example, intracycline in combination with trastuzumab. Or I try to recommend giving intracycline over prolonged infusion, 6 hours or 24 hours in comparison to 30 minutes. Giving prolonged infusion is associated with lesser cardiotoxicities. For bone metastasis, we recommend bone modifying agent. And for hot flashes, I recommend avoiding fluoxetine with tamoxifen. And we also do fertility preservation counseling to our patient. And with that, thank you so much. And that's my email address, khanma1, sorry, one is missing here, khanma1@ngh.md.s. If you have any question, you can send it to me. Thank you so much. I hope I finished my lecture in 28 minutes and I was assigned 30 minutes. Thank you so much.
Thank you very much, Dr. Mansoor, for such a wonderful and nice presentation. It was really informative. और बिल्कुल सर, बिल्कुल आपने बिल्कुल टाइम पे माशाल्लाह अपनी कंक्लूड कर दिया सेशन को. जितने भी सामाईन और नाजरीन हैं हमारी ऑडियंस जो है वो सवालात पूछ सकती है हमसे यूट्यूब लाइव पे कमेंट सेक्शन में, और सर्टिफिकेट्स के हवाले से जो सवाल है इंशाल्लाह सर्टिफिकेट्स भी आप लोगों को मेल कर दिए जाएंगे फीडबैक फॉर्म के फिल होने के बाद. अब हम चलते हैं अपनी दूसरी स्पीकर की जानिब, और ये भी किसी तारुफ की मोहताज नहीं है. इन्होंने भी कीमो फार्मेसी में बेतहाशा काबिल कदर खिदमत सर अंजाम दी हैं. डॉक्टर समीना बदर, शी इज द PharmD MBA गोल्ड मेडलिस्ट, हॉस्पिटल एंड हेल्थ केयर मैनेजमेंट Certified Clinical Pharmacist, Queen's University, Belfast, UK. ISO Lead Auditor, IRCA, UK. She is currently serving as Deputy Manager Pharmacy, Shaukat Khanam, Karachi. I'm sharing your screen, ma'am. Over to you.
Thank you. Bismillahirrahmanirrahim. Assalamu alaikum and good afternoon to all. Am I audible, Zad?
Yes, ma'am, you are audible. Yes, ma'am, please proceed.
Okay, great. Thank you. First of all, thank you very much for your kind introduction, and thank you giving back to pharmacy in Pakistan and nurturing community pharmacy in Pakistan for organizing such an required session in the month of October, which is entitled as Breast Cancer Awareness Month. And it's much needed to spread the awareness regarding early detection of the breast cancer. Also, thanks to Dr. Mansoor for such an extensive presentation, and almost majority of things are covered by him. So I will touch some other aspects of breast cancer regarding risk factors. We will talk about some of signs and symptoms and the screening and awareness of the breast cancer. And also we will talk about a little about the HER2 receptors positive breast cancers and their management. Zad, could you please move forward? We all know that, next please. We all know that breast cancer is the most frequently reported cancer in the woman, and 1 in every 9 women are diagnosed with the breast cancer. Usually, breast cancer is a disease of females, but it also occurs in male. The ratio is much less as compared to females, but it can happen in males also. And now there is no gender discrimination that it is only the disease of females. Male breast cancer can also occur, but it's rare and less than 1%. Cancers are usually breast cancers. Usually when we talk about the breast cancer, it is considered as the second most common cancer, which is causing deaths in women. Although down the years, in US and other Western countries, the trend is declining due to the availability of new systemic therapies, and also their screening is improved. But as far as Pakistan is concerned, we still need to do a lot more. And I would share here that a publication of Journal of Pakistan Medical Association, which states that 40,000 women are died of breast cancer each year, and 90% can be improved through breast cancer screening. So we can think about it that why our women are presenting late, in late stages, in advanced stages of cancer, and how we can improve screening possibilities in our region. Because if you see breast cancer, it's all around the world, it's reported. But if we talk about Asia, Pakistan is the country which is presenting with topmost breast cancers in Pakistan. So there's a dire need to address this dilemma, that how we can improve screening and awareness in our women, and how we can defeat this deadly disease. Usually, as I said earlier, that 1 in every 9 women diagnosed with the breast cancer, and you can see that this is a disease of older age, like around 45 onwards, the women are presenting with this complaint. And basically, the signs and symptoms are not so prominent when the tumor is small. And this is the main thing, that it is delayed at this stage. If we can find out the tumor in earlier stages, then obviously this is much easier to take decision about treatment. But typically, when the breast cancer starts developing, then there are no signs and symptoms. And when it appears or it is diagnosed through some other way outs, like through if a person is suffering from some other disease and she goes to the doctor for checkup, and accidentally it is diagnosed that like check your ultrasound, do your ultrasound, and the findings are suspicious. So ultimately, these are some of the ways that breast cancers are diagnosed in Pakistan. Otherwise, mostly the lumps which are diagnosed are painless, and females usually neglect them. That they are not of any concern until and unless, because our females in Pakistan and are quite reckless, or they are more towards doing things as priority, but their health is secondary. Basically, as I said, the lumps which are screened, which are identified through screening, are painless lumps, but in later stages, swelling, heaviness, and pain occur in later stages too. So females should look about the painless lumps, swellings, and redness, skin changes, size of the breast, and nipple changes like nipple retraction or any sort of discharge, especially the bloody discharge. These are some of the major things where a female should be alerted, or should take precautions, and should go towards a family physician for a checkup. The next is risk factors. As I mentioned that now breast cancer is not only the disease of females, but it is also affecting the males. So everyone is at risk of developing the breast cancer, irrespective of the class, creed, or gender. And there are some factors which can increase the risk of developing the breast cancer. We can categorize them into modifiable and non-modifiable risk factors. What are the non-modifiable factors? As the name indicates, which we can't modify, like the growing age. Risk of breast cancer increases as the women get older, and about 80% of the women diagnosed with breast cancer each year are in between the age limit of 45 and older. The next is female gender. If we see the data of Pakistan, usually the ratio is 40-60. Like 40% of the cancers are male, in male gender, and 60% cancers appear in female, presence in female gender. So female gender is mostly reserved for breast cancer, ovarian cancer, colon cancers, and these sort of cancers which can present in female gender due to the obviously their anatomical changes with the passage of time, and all the hormonal changes during their life cycle. Family history of breast cancer is very, very important, because if you have any first degree relative who suffered from cancer disease, like mother, father, any sibling. So according to the studies, around 1.5 times higher chances in those who have first degree relative. And if one relative who had suffered from the breast cancer, the chances are 1.5. But if they are more than one, then around 2 to 4 times higher chances for those women who have more than one first degree relative who suffered from breast cancer. Early onset of periods is also very important, because that time period during which the cycle starts and the cycle ends. Both time periods are of important with respect to the breast cancer. If the onset of periods are earlier, before the age of 12, usually approximately 20% higher chances of breast cancer are in those, according to one study, in those patients who are of 11 years versus 14 years old. Like if it appears, if the cycle appears in 11 years of age, then there are 20% higher chances of breast cancer presence as compared to 14 years old. Likewise, a woman who experience menopause in the later stages, like at the age of 55 or older, they have about 12% higher risk as compared to those women who have 50 to 54 years of age. And this risk is could be due to the long time exposure to the reproductive hormones. So the other non-modifiable factors could be delayed first childbearing age, like a kid after age of 30, and or the reverse case, like no childbearing. This could also be the reason of breast cancer. Genetic predisposition is very important, and it accounts for about 5 to 10% of the cancers. Inherited pathogenic genetic variation, BRCA2 and BRCA1, these are most common genes which are involved, and their mutation can lead to the breast cancers. Genetic testing is basically recommended for those families who have inherited picture of breast cancer in their families. And this age, you can start the screening earlier in those families who have already the genetic element running in their families regarding breast cancer or any cancer. The next is personal history of breast cancer. If a woman is already diagnosed with breast cancer in the past, she also had the risk of developing new cancer during 10 years of that time period, and the risk is around 3 to 7%. However, in the past few years, due to the use of aromatase inhibitors and therapies like tamoxifen and Femara and other aromatase inhibitor, this risk is quite reduced, but still it is present, and these patients should remain on continuous follow-up with their physicians. Modifiable risk factors, the first thing which is foremost important is your diet. If a female, or including the whole male gender also, they are using a fatty diet, junk food, or sedentary lifestyle is there. So there is possibility of increased risk of breast cancer, and according to different studies, the possibility of cancer reduces when you are using mostly vegetables, fruits, and fish proteins and nuts, etc. So your diet is very important in curtailing this sort of cancer. Then the physical inactivity. Physical inactivity, those women who do the regular exercise and physical activity have 10 to 20% lower chances of breast cancer as compared to the women who have sedentary lifestyle and who are not physically active. Try to add some sort of exercise on daily basis, like brisk walk for 30 minutes, or involved in some sort of sports, good sports, so that you can cut down your pounds as well, and also you can cut down your risk of breast cancer. Excessive weight is also very important. If not only from the breast cancer point of view, but also from the other many diseases like cardiac diseases and some other. The thing is that post-menopausal women, like in them, the breast cancer risk is about 1.5 to 2 times higher who are overweight or obese and having higher BMI as compared to those who are not so much obese and who are having a healthy lifestyle. So reduce your weight and involve in some physical activity. It will definitely improve your survival as well. And obviously you will be prevented from deadly disease like breast cancer. The other modifiable risk factor, breastfeeding. Breastfeeding, usually the women don't think that breastfeeding should be taken for a longer time for their kids. But as per Islamic belief, obviously being a Muslim, it's every woman should breastfeed their child for 2 years at least. And now the studies are also suggesting that if you are breastfeeding your kid for a year, then it will reduce around 4% of the chances of developing breast cancer. And if you could use that Islamic Sunnah, then obviously 8% of the breast cancer chances you are cutting down, and obviously your child also getting the good nutritious upbringing. Smoking, tobacco is the main culprit, and obviously the lung cancer is the most important cancer, which is related lung and oral cancers also. But it is also causing one of the factors of the breast cancer, irrespective of that it is also causing the 15 other cancers. So smoking in the form of active smoke or passive smoke, both sort of smoking we should avoid. And also not only this condition can affect yourself, but also the nearby persons who are living with you, your families, your kids. They can also affect it if they are getting exposed to smoking in the younger stage. Alcohol is also one of the major modifiable risk factors. So if the person can avoid alcohol consumption, although Pakistan is not candidate for this thing, this is not the factor, but in West, obviously, alcohol consumption is common. So alcohol consumption, if a woman can reduce from their diet, there are chances about 7 to 10% that they can not get the breast cancer in their life. Hormone replacement therapy, one of the major area which needs attention. Because use of menopausal hormones or HRT can lead to breast cancer, especially in those women who have started it soon after the menopause, as compared to those who began it in the later stages. And the important thing with HRT is that once you discontinue it, you can reduce the incidence of breast cancer, but you can't eliminate the risk of breast cancer. So this is very important that once you start HRT, there would be a risk of developing the breast cancer in later phases of your life. Use of oral contraceptives, it is associated with around 20% relative increase of breast cancer, and risk reduces when the woman stops taking oral contraceptives. Usually it is indicated that oral contraceptives should not be taken beyond 4 years. It should be taken less than 5 years, because after 4 years, or if a person is taking around 10 years, obviously it's a greater risk towards development of breast cancer. But on the other hand, contrary to that, if a woman stops taking, and if she is not taking contraceptives for the next 10 years, then it is similar to those who never use the oral contraceptives. Some environmental factors like radiation and like atomic radiation is also causing breast cancer, because in the past we have seen that majority of patients from Afghanistan, where a war was going on. So radiation exposure, and either in the form of therapy to females or through atomic energy, in any form, radiation exposure may cause breast cancer. Some of the medicines like DES, which is called as diethylestylbestrol, it's also one of the cause, and it can develop around 30% risk of developing the breast cancer in those women who took it in around era of 1940 to 1971. Some other environmental chemicals and pollutants may also cause breast cancer. And here I also want to share one thing, that night shift work. This is one of the major thing which is proving to be one of the factor which can cause cancer in women and in the later stages. So those nurses who are working or night shift, pharmacists, nurses, and all the healthcare professionals who are working night shift, flight attendants, they can experience a circadian rhythm caused by cross multiply time zones, and they have found increased risk, which is basically due to the melanin production disruption. And finally, as we all know, that melatonin production is involved in reduction or reducing the growth or inhibiting the growth of small tumors, and it also prevents developing new tumors. So ultimately, it controls the development of tumors. And if during night, all the night you are wake up, so obviously it would not produce, and the safety mechanism or prevention which is given by Allah, it would not be achieved, and finally you will be more prone towards developing the breast cancer. This is one of the study related to hormone contraception, and this study indicates that 15 to 49 years of age who used hormonal therapy, 1.8 million women have developed the breast cancers, followed for 10.9 years. Relative risk was 10 years use was 1.38. With progestin, it was progestin intrauterine devices, it was 1.21. And after stopping, risk remained high if it is greater than 5 years of use. So oral contraceptive should always be used less than 5 years in any case. Otherwise, it would be a problem, or it would be a reason towards developing breast cancer. Tumor markers in breast cancer, we have 3 tumor markers which are used for monitoring the breast cancer. Cancer antigen CA115-3, CA27.29, and carcinoembryonic antigen, which is CEA. These 3, CEA is also the tumor marker for colon cancers and lung cancer and some other cancers, but it is also one of the tumor markers for breast cancer. These 3 tumor markers are usually used, which give us the indication towards the disease advancement, and the therapy choices. It helps us that it also help us towards giving some idea about the management of the disease, either it is good, going good, or towards the management is satisfactory, or a physician has to change some alternatives or some other way out to change the medication related to the cancer management. So, but it would not give you the idea that is there any possibility of recurrence, that when a breast cancer recurrence can occur, or how we can improve the disease-free survival. So these are some of the things which we keep in mind before exploring the role of tumor markers. If the breast cancer is diagnosed in the early stages, 5-year during diagnosis, then the survival chances are, as Dr. Mansoor said, that survival is good, and prognosis is obviously it's around. It's not so much worst in Western countries, but here, as it is presenting late, so prognosis is not good. If a patient appears in the early stages of the breast cancer, then the 5-year survival is around 91%, and 10-year survival is around 84%, 15 years is 80%. There would be a slight change if we see ER/PR receptors and monoclonal antibodies or targeted therapies. So if we could say that if a patient has ER/PR receptors positive, then the survival would be 91%. But if ER/PR positive receptors negative, then the survival would be 89%. So around 1 to 2% difference is there. But initial stages would have a very good survival, and the patient can run a very happy and healthy life if they diagnosed earlier, if they got treated earlier. Early detection is the basic thing, which is the best protection, and we should go for early detection of the breast cancer so that treatment would be possible. Screening and detection, usually the methodologies which are used are, the first one is, which is not costing much, and it's in your hand. You can do it yourself. You can plan a monthly day where you can assess your breast yourself, which is called breast self-examination. It is done on monthly basis. For premenopausal women, you can do after 1 week of cycle ends, and for postmenopausal women, you can select any day in a month, and you can go for a breast self-examination. And if you find any suspicious lump in your breast, you can contact your physician and go for further assessment. CBE, which is clinical breast examination, this is also a very good tool to get early detection, because it is by a qualified physician, and the possibility of detection is more through CBE. So if a female has some suspicious lump in the breast, in later stages, she can contact any good physician and can go for clinical breast examination. The most common thing which is given by a physician, or which is suggested by a physician after these 2 steps, is ultrasound. If a female is less than 40 years of age, usually bilateral ultrasound is recommended for screening purpose, so that they can find out that either the lump is benign or lump is malignant. And if a female is above 40 or after 40 years, mammography is available to detect suspicious lumps, and for further management, they can refer to the oncologist. MRI is also suggested in those cases where micro-level disease is usually required to find out, because the small lesions are not visible in through ultrasound and mammography, and they are more clear in the MRI. So it's more sophisticated technique than them. So in some cases, MRI can also be used, and especially those cases where genetic predisposition is there, and families have cancers in their families, running in their families. These patients are usually candidates for MRI, so so the physician can get the complete picture and the micro level disease as well through MRI. Now, this is a very important question, that why our patients are appearing late in Pakistan. Why the females are not picked earlier, and they are appearing in the advanced stages. And then we have no, like, oncologist or the whole team has no option to suggest them that आखिर में ये होता है कि they usually used to say कि हमारा मरीज बच जाएगा डॉक्टर साहब. तो डॉक्टर साहब has nothing to say, because इतनी late stages में जब वो present होते हैं, तो obviously it's too tough for oncologist. कि वो कहते हैं ना कि आप उम्मीद देते हैं, physician एक उम्मीद देता है, तो how he can give hope to that family. There are some reasons why late presentation of breast cancer patients in Pakistan, and it is multiple studies are available related to Pakistani context, where they find out that what could be the reasons related to the late presentation of breast cancer. The first thing is low literacy and awareness. We know well that our more than 70% population is living in villages and in areas where basic necessities are also not available. And basically, this is also very important that females are reluctant to discuss this topic because in their youngerhood, through families, it's been taught to them that it's not the good thing to discuss about your private parts. And from there, they always used to like hide things, and they never share their problems openly with the families, and especially even like their brother, father. It's not the culture that they are encouraged to share their complaints in their family easily. So this is one way, and the majority of families are headed by males, there's no doubt, but their family decisions are also taken by males related to health. So the male, and we are not discussing this thing with male, then obviously you can imagine that what could be the result, that obviously they will be present late when they got some pain or they got some serious symptom, and then it's too late. Ignorance of the disease, shyness, embarrassment, it's already, I think it's been covered that you should come out of this embarrassment and shyness. You should own your body, you should own your organs, and you should discuss with you should discuss your problems with your physician at least, and you should discuss with your problem first with your family. Prior use of herbal or unconventional treatment, or you can say it, alternative treatments, in this context, you can discuss spiritual healings that people start down the road and going towards some peers, and like ये सारी चीजें start हो जाती हैं कि एक दूसरे को बताता है जी कि मेरी फैमिली में ये हुआ था तो मैंने वहां दिखाया था, उन पीर साहब के पास हम गए थे तो ठीक हो गया. और इस तरह से फिर कुछ होम्योपैथिक एंड हिकमत मेडिसिन्स आर देयर which people start, or disease जो है, we know it's a rapidly dividing disease and ultimately ends up in advanced stages when patients appear to us. This is also a stigma, unfortunately, and females start isolation, self-isolation in their homes. They don't want to meet with relatives and family because they don't feel comfortable that somebody shows sympathy towards them. And also there are relatives in all our families who start like discussing those patients कि फलां खातून जो है उनको तो तुम्हें पता चला तो कैंसर हो गया उसे. तो ये सारी चीजें जो हैं अब वो फिर उसको रिलेट भी किया जाता है कि यार ये टुवर्ड्स अल्लाह कोई चीज मसला हुआ होगा तो अल्लाह ताला ने देखा कैसा सही वाला बदला लिया है. तो ये चीजें बहरहाल फैमिलीज में होती हैं, एंड डिस्कशंस इस तरह के जब होते हैं और वो चीजें पेशेंट्स तक पहुंचती हैं तो फिर ऑब्वियसली पेशेंट्स जो हैं वो खुद को सेल्फ आइसोलेट करने की तरफ चले जाते हैं और फिर चीजें जो है वो साइकोलॉजिकली वर्स्ट होती जाती हैं. Other things include they felt hesitant because once it's diagnosed that it's a lump and surgically needs to be removed, obviously operation. तो ऑपरेशन का नाम सुन के ही सबसे पहले तो जो है वो बुरी हालत हो रही होती है पेशेंट्स की कि नहीं हम किस तरह से ऑपरेशन कराएंगे, क्या होगा. So lot of questions. You can't even imagine कि जब ये चीज एक फैमिली में भी इवन अपीयर होती है तो किस तरह से फैमिलीज जो हैं वो कोलैप्स करती हैं. और इट्स वेरी डिफिकल्ट टू एक्सेप्ट. इवन आई वुड लाइक टू शेयर माय यंगर सिस्टर. she was under like in I guess 15 years old when she felt a lump in her breast, and we went for surgical removal, and alhamdulillah it was benign. But during that time period, the stress which we all felt, it can't be explained. Now she's living a healthy life, but at that time it was a horrible thing to accept. So acceptance, for acceptance, family's role is very important. Families counseling, families empathy. These are the things which makes the patients more stable. And also the non-availability of treatment modalities in nearby cities, like we have not so much cancer facilities available in Pakistan. A few modalities like and a few cancer facilities like Shaukat Khanam and like some other, they are working, and they are not enough. And the last thing, fear of cost of treatment, low socioeconomic status. As you know that it's a stage of 45 onwards. So after 45, it's the time to their kids are grown up, they are planning for their higher studies or their marriages. So they are in a mode to keep savings with them. तो उस टाइम पे ये होता है कि जी जितने पैसे हों बचा लिए जाएं, बिकॉज अपने बच्चे के लिए ये भी करना है, ये भी करना है, ये भी करना है. So it's a time of saving for parents. But unfortunately, if at this time a female develops a breast cancer, so obviously they would not be in a position कि वो उसको जो है वो उनके पास इतना अमाउंट हो कि वो उस चीज को इतनी हैवी कॉस्ट ट्रीटमेंट्स को वो बियर कर सकें. So this is also one of the reason of reluctancy that people felt कि जी अब जो जितनी जिंदगी अल्लाह ने दी है वो पूरी करेंगे, or they not go for treatment. But after some time, when pain starts, when the things went out of order, they rush to hospitals, and obviously then it's like advanced disease and the physician can't do more. These are some of the cancer campaigns which Shaukat Khanam hospital is doing.
Ma'am, extremely sorry to disrupt you for the intervention. Soft reminder, ma'am, we are running out of time. So just a short soft reminder.
I am wrapping up. Treatment of breast cancer, as Dr. Mansoor said, surgery, chemotherapy, radiotherapy, hormone therapy, and targeted therapies. Breast cancer management is done through different chemotherapeutic agents, and one is HER2 receptors. This accounts for 15 to 30% of the breast cancer, in which the HER2 receptors overexpression or amplification is detected. So for those cancers, we do testing through immunohistochemistry and FISH testing, fluorescein in his C2 hybridization. And if it's 3+, or if it is 2+, but with FISH it is positive, these patients are candidates for the therapy. Trastuzumab is the first anti-HER2 antibody which is approved for use in metastatic breast cancer. For the guidelines regarding NCCN, as Dr. Mansoor said, usually the first preferred agent is like trastuzumab, and if we like due to time constraints, if you see this, that in cases of recurrence or metastatic diseases, the first line agents are docetaxel or paclitaxel with trastuzumab. And we can add them pertuzumab with this. Second line is adotrastuzumab and benzene. And the third line, like litucatinib, trastuzumab, capecitabine, and capecitabine, trastuzumab, lapatinib, and niratinib, capecitabine. These all are the third line antibiotics, anti-monoclonal antibodies, which are used while looking at the patient characteristics and obviously the toxicities which patient is experiencing as disease progression. So coming to recommendations, availability of a screening program at national level is the much need of the time, and sustainable goal 3, which is good health and well-being. Government can add this goal also, this project also in this, that the breast cancer screening program should be included in SDG 3. Women cautious approach is very important. Women should own their organ, and women should pay respect towards themselves. A woman should take care of themselves in order to get rid of this disease and in order to defeat cancer. A caregiver support and counseling is of much importance, and availability of facilities which can deal with cancer. They are the need of the time, and not 2, 3, 4 hospitals, but we need more according to the number of patients or number of our population which is suffering from cancer. Thank you for your patient listening.
Thank you very much, ma'am, for such a nice presentation. Again, मेरे ख्याल से सामाईन और नाजरीन बेहद जो है मुस्तफीद हुए होंगे आपकी प्रेजेंटेशन से और डॉक्टर मंसूर से भी, क्योंकि टाइम हमारे पास ऑलरेडी मैम और सर आगे हो चुका है हमारे डिसाइडेड स्केड्यूल से। तो बस एक एक सवाल हम जो है वो आप दोनों से करना चाहेंगे जो हमारे ऑडियंस ने किया है। सर मंसूर, एक सवाल आपसे है, पूछ रही हैं खातून कि व्हाट आर द अप्रोचेस फॉर ट्रीटिंग एडजुवेंट एंड न्यू एडजुवेंट ब्रेस्ट कार्सिनोमास?
Repeat the question, please.
सर सवाल है, what are the approaches for treating adjuvant and new adjuvant breast carcinomas?
Very good. So the thing is that if the patient present, just let me turn off the AC because it is causing a lot of noise. Just a second. So the thing is that for the neoadjuvant breast cancer, we talked about that the people would like to take the breast conservation surgery in stage 1 and 2 disease. Usually you don't need preoperative chemotherapy, and you can just go through the resection. The surgical oncologist can do the resection, and then they can go for the adjuvant. They have to take the adjuvant radiotherapy as well as the adjuvant chemotherapy. But for the stage 3 disease, which is T3 and T4 tumor, which is the tumor more than 5 centimeter or is involving the chest wall. So in that case, the surgical margins to achieve negative surgical margins is pretty difficult, and you have to do invasive surgery. So for that reason, you have to give preoperative chemotherapy or neoadjuvant chemotherapy in that setting, where you can downsize the disease and you can shrink the size of the tumor by giving the neoadjuvant chemotherapy, which is 4 to 6 cycles. In HER2 positive cancer, we use trastuzumab, pertuzumab combination, dual HER2 blockade. And in HER2 negative disease, we can use dose-dense AC followed by paclitaxel, particularly in the lymph node positive disease, for 4 cycles. And then we evaluate them for the response. And then they are actually taken for the surgery. And then we have to achieve the negative margins. And then we proceed with the adjuvant chemotherapy if it is required. And they have to take also, if the lymph node disease is positive, they have to take the radiation therapy. If they are going to the breast conservation surgery, they have to take the adjuvant radiotherapy, and they have to take the adjuvant endocrine therapy in case if they have ER/PR positive disease for 5 to 10 years. And if they have HER2 positive disease, then they have to take trastuzumab containing regimen based on the HERA study for about 1 year. And even you can take another line for another 1 year. And those patients, after the neoadjuvant chemotherapy, preoperative chemotherapy in HER2 positive breast cancer, if they are having residual tumor, which is found in about 35 to 40% of patients, according to one study. Now, the new standard of care is to use trastuzumab, which is TDM1, which is associated with much better outcome in comparison to pertuzumab and trastuzumab dual HER2 blockade as adjuvant therapy. So TDM1 is more effective in those kind of patients.
Thank you very much, sir. Dr. Samina Badar, आपसे एक सवाल है कि what are the side effects associated with mammogram to the breast tissues?
Basically, mammography is a radiation modality which can give, a patient can expose to radiation, like in X-rays or as compared to ultrasound, which is not ionizing radiation. Mammography में आप जो है वो radiation से expose होते हैं, but that radiation is not of much you can say it is of acceptable range, which can be used safely in humans to get the desired images or get the desired their objective. Mammography is related to ionizing radiations, but it's not of that much harm that you think mammography से, because it's a misconception that mammography अगर आप yearly करा रहे हैं तो मेमोग्राफी से भी जो है वो ब्रेस्ट कैंसर के चांसेस होते हैं। तो ऐसा अभी तक कोई स्टडी रिपोर्टेड नहीं है और ऐसा कुछ नहीं है। रेडिएशन जरूर इन्वॉल्व होती है उसमें, लेकिन इतनी रेडिएशन नहीं होती कि जिससे आपको ये हो कि जी उससे जो है खुदा न खास्ता ब्रेस्ट कैंसर का रिस्क हो सकता है। द अदर मोडालिटीज से हम एमआरआई कहते हैं, एमआरआई में भी जो है वो रेडिएशंस नहीं है, जस्ट लाइक अल्ट्रासाउंड। So ultrasound and MRI are the safest modalities, but if you are doing mammography, there is a little risk of getting some radiation, just like X-rays. Thank you.
बेहद शुक्रिया मैम, बेहद शुक्रिया सर मंसूर।
I think we answered maybe more than 100 questions while Dr. Samina was presenting.
जी बिल्कुल सर, बेहद शुक्रिया। क्योंकि वक्त की बंदिश की वजह से हम मजीद सवालात लेने से कासिर हैं, लेकिन जो हमारी चैट है यूट्यूब पे, वहाँ पे डॉक्टर मंसूर ने काफ़ी सवालात के जवाब दे दिए हैं। मजीद कोई सवालात हैं तो आप मेल भी कर सकते हैं और चैट में भी पूछ सकते हैं। इंशाल्लाह हम कोशिश करेंगे कि अपने स्पीकर से उनके जवाब ले सकें।
बिल्कुल डायरेक्टली पूछा जा सकता है, ज़ात से आप कांटेक्ट कर सकते हैं अगर कुछ ऐसे क्वेश्चंस हैं तो वी कैन आंसर। थैंक यू।
बिल्कुल, हम फॉरवर्ड कर देंगे और इंशाल्लाह आपको जवाब मिल जाएंगे। मैं एक बार फिर शुक्रिया अदा करना चाहूंगा अपने दोनों मौजूद स्पीकर्स का, गिविंग बैक टू फार्मेसी इन पाकिस्तान उनकी टीम का, डॉक्टर अफसर डॉक्टर सिद्दीकी, नर्चरिंग कमेटी फार्मेसी इन पाकिस्तान की टीम का, डॉक्टर समीना और उनकी टीम का। और हम उम्मीद करते हैं इंशाल्लाह ये सिलसिला हम बरकरार रखेंगे और हर महीने 1 या 2 प्रोग्राम्स आपके सामने जो है वो पेश करेंगे। आज के लिए बस इतना ही। बहुत शुक्रिया, अपना बहुत ख्याल रखिएगा। अल्लाह हाफिज़ नासिर।
आप सब लोगों का बहुत बहुत शुक्रिया। Thank you so much once again. Assalamu alaikum.
Assalamu alaikum.